Good afternoon, everyone. This is Morgan from the New England QIN-QIO, and I just want to thank you for joining today's Interact webinar on the Quality Improvement Tool and Medication Reconciliation Tool. Before we get started, I'm going to quickly review a few housekeeping things. This call will be recorded, and the presentation will be available within a few business days after the webinar, and I'll provide you with instructions on accessing that at the end. Phone lines are on mute for the duration of the presentation. We will be taking questions at the end, and I will provide you with instructions on how to unmute your line at that time. And now I'd like to pass it over to Carol as we get going.
Good afternoon, everyone, and welcome to all the nursing home staff members joining us this afternoon. I am Carol Dietz, as Morgan stated, and I'm one of the QI consultants from the New England QIN-QIO, and I'll be the moderator for this session today. I'm here with Sheila Eckenrode and Florence Johnson, who are going to be the presenters for this afternoon. Next slide, please. The objectives for today's session are we're going to get a good understanding of the root cause analysis process, also known as the RCA process, from Sheila. And then Florence is going to be reviewing the Interact Quality Improvement Tool for review of acute care transfers. And also, Florence will be reviewing how to use the Interact Medication Reconciliation Tool. And then, before we close out the large group session, we're going to talk about developing a plan to implement the two new tools into your facility. And then at the very end, we're going to be splitting up into state-specific discussion groups for those nursing homes that are part of the State Quality Improvement Initiative. Next slide, please. So just to remind everyone, we have 6 states that are part of the New England QIN-QIO. Connecticut, with Florence, myself, and Sheila, who are the task leads for this initiative, this care transition work. In Rhode Island, it's Kathleen Calandra and Nelia. In New Hampshire, it's Joyce Johnson and Margaret Crowley. In Vermont, it's Liz Keltner. I say that name, Liz, wrong all the time, and I apologize. And Gail Harbor. In Massachusetts, it's Lynn Chase, Cheryl Leary, and Lori Niervon. And in Maine, it's Maureen Leahy. So I just want to make sure everyone realizes that we're all in this together. We're all trying to improve patient care and resident care throughout the New England region. So now I would like to introduce Sheila Eckenrode to talk about the root cause analysis process and how important it is to any quality improvement work. We decided to provide this information first and then get into the review of the two Interact tools, since the tools are actually part of the RCA process. So it's important to know the process before you know what tools to use. So Sheila, the floor is now yours.
Thank you, Carol. Good afternoon and welcome back, Interact partners. Since we are going to be discussing the Interact Quality Improvement Tool, I wanted to spend a few minutes talking about the root cause analysis process, since the Interact Quality Improvement Tool actually provides a framework for this process as it relates to looking at unplanned readmissions. In root cause analysis, I'm going to assume that it's something that some of you are very familiar with, maybe some of you are somewhat familiar with, and it might be a new concept to others. So if you can bear with me, I'd like to do some level setting, just give some definitions and some examples of what a root cause analysis looks like. So a definition, a root cause analysis is a structured evaluation method that identifies the root causes for an undesired outcome and the actions needed to prevent recurrence. So if we think of a medical error or an unplanned readmission as the tip of the iceberg, a root cause analysis is designed to reveal the rest of the iceberg. Some terms that you'll hear bandied around about root cause analysis is the sharp end and the blunt end. Again, it's the tip of the iceberg is the sharp end, the bottom of the iceberg is the blunt end. So in healthcare safety, we talk about the sharp and blunt edge of a medical error or an unplanned outcome. Sometimes the blunt edge is also referred to as a latent cause. The sharp edge is where the error or problem is observed, where it occurs. So that's usually at the point of interaction with a resident, a patient, or another caregiver. The blunt edge is everything that came before that moment. So it's policies, procedures, culture, decisions that came before the moment that the error occurred. For example, a medication occurs because an IV pump is set up incorrectly. That's the sharp edge. That's the point of error. But all that came before it contributed to that error. So everything from how the person was trained to use the IV pump, decisions made about training, perhaps the nurse was given written instructions instead of live training because there were some changes in staff development, some budgetary constraints that made it harder to provide instruction. Perhaps purchasing decided to purchase several different IV pumps rather than one. So now a nurse is tasked with knowing how to program several different pieces of equipment. Go all the way back to the manufacturer. Did they put any controls in to make it harder to make errors? So when we talk about a root cause analysis, that's where we're going. We want to dig really deep in there and see all the contributing factors to that one moment, be it a medical error or an unplanned outcome, such as an unplanned readmission. So if I can start with a polling question, have you ever conducted a root cause analysis in your facility for any reason on a readmission, error, fall, sentinel event? And let's give folks a few minutes to answer that. Working just advise me to remind everyone to hit the submit button after you hit yes or no. So if you can take a minute to answer that question, it'll help us all know where we are. And looking good. Well, I am thrilled to see this practice taking hold in healthcare. But again, in order to do some level setting so we all start in the same place, just going to take a few moments to describe the root cause analysis process. Now, there's tons of literature, and there's many, many places you can go to learn about root cause analysis. On the internet, there's classes. JCHO has a module to learn about it. So does CMS, and so do I. If you want to know more, please feel free to call me or contact me. My contact information is on this PowerPoint. There's, I can go on and on and on about that, and as my colleagues will tell you, I could go on and on about other things too, but I'm just going to do some level setting, keep this kind of very simple. All right, so I am very pleased to see how many people are doing this. Root cause analysis, what are we looking for? Okay, so it's going to help us determine what happened, how it happened, and why it happened. And usually the what happened seems to be the simplest thing, but not always. I recall looking at a series of falls that a resident had taken shortly after being put in bed, and as we did some digging around that and analyzed the information we had, we determined that the resident wasn't actually falling out of bed. She was crawling out of bed to kneel down and pray, which was a habit that she had all her life. So, what happened? But usually with a readmission, we know what happened. The patient was readmitted. The patient was sent to the emergency department. Someone made that decision. How it happened and why it happened. So here's an example that I'd like to walk through with you. A new dietary aide is hired to be in your kitchen. And on the evening shift, she's putting away some kitchen equipment, and she cuts her hand on a knife. She requires several stitches. She experiences pain, frustration, erodes her confidence a little bit, and you as administrators are left with all sorts of paperwork and filing to go with that. So we know what happened, and we know a little bit about how. So the next thing we want to know is why. So in conducting root cause analysis, we're going to start by asking the dietary aide what happened. When we look at readmissions, we're going to open up the chart, review the record, we're going to interview the people who are there, and that's very important. Sometimes, we tend to do these things in morning report, and it's a group of people that work well together and understand the facility and the culture, but it might not be the people who are there at the moment. So whenever we can get those folks in the room, it's all the better. This doesn't have to be an hour-long meeting. These can be huddles where a group of people just get together to talk about what happened and their understanding of why. You're going to start with some data collection, reconstructing the event in question through record review and participant interviews. Then you're going to talk about how it happened, analyze the sequence of events leading to the error, or in our case, an unplanned readmission. So maybe in the morning, the nurse practitioner rounded, she saw this resident, she wrote some new orders, make a sort of timeline on paper as to what led up to this. And then we're going to get down to why the event occurred, and that's really the meat of this. So when we have a reasonable understanding of what happened and how it happened, we want to talk about why it happened. And a good exercise to use in determining the why and the latent causes or blunt edge of a problem is to simply ask the question why 5 times. You might have walked through this exercise in a class, you might have seen it, but it would go something like this. Going back to our unfortunate dietary aide with her hand laceration, we might start out asking why that happened. So we know what happened. She cut her hand. We determine how. She was moving some boxes, and there was a knife left on the counter. Why was the knife on the counter? It wasn't put away. Why wasn't it put away? Well, it was a new piece of cutlery recently added to the kitchen, and there was no set place for it. So it wasn't put away because there was no place to put it. Well, why not? Because no one was designated as the person to find places for the new equipment. There was no process or designation as to who would get rid of the old equipment. So if those questions led us down a different path, that there was a place for the knife to be put, and the dietary aide before our wounded warrior chose not to put it away or forgot to put it away, that would lead us down a whole other path. If someone forgot to put it away, why did they forget? If someone didn't know where to put it away, why didn't they know that? So you can see how you're just sort of peeling back layers of an onion, which is going to result in a much more robust and powerful solution to the problem. So as you go to use the Quality Improvement Interact tool, I'm going to encourage you dig a little deeper and try not to stop at a diagnosis or a symptom, because that's a natural wall. Why does this patient go to the ED? Because they had an exacerbation of their COPD. Why? Because they have COPD. Why? Sometimes the question to ask when it comes to unplanned readmissions is, why today? Why did this person's condition change and deteriorate today when they were okay on Monday or they were okay last Friday? Opening up the chart again, asking why, getting a lot of people to throw out their ideas. Once we get a group of possible causes, the next natural place to go with that is to group them where they belong. So if it involves equipment or procedures, put all of those together in a little pile and see where there's some linkages. And that's how we begin to make some changes and to talk about interventions. So again, my dietary aid, if there was no place to put the knife, you might think of some visual reminders. Hooks on the wall where the knife would go, maybe with the knife outlined on them or labeled. So the last person to leave in the afternoon can scan the wall and see if anything's missing. It's a lot easier to look for things that are missing than to try to remember what to put in there. Lots of different tricks like that, and lots of information on root cause analysis, human factors, safety, and sort of mistake-proofing processes are available to us in healthcare today. And that's great because it's relatively new. I'd say like in the last 10 or 15 years, we've started to adopt some of these safety practices from industry and the armed forces, since there a lot of them come from. And when I first started out in nursing back in the day, there were two ways to look at a problem. Something went wrong and someone was blamed. And then the same thing went wrong and someone else was blamed. And we continued that ad infinitum, and it didn't get us very far. So I'm delighted to see how many people do perform root cause analysis and do this type of deep, critical, analytical thinking in their work. And with that, I am going to turn this over to Florence, and she's going to talk about the quality improvement tool.
Thank you, Sheila. So I'm sure you guys know by now that I love polling questions, and to serve as a review, we have been doing this for about 4 weeks now, and I just wanted to make sure that we are all on the same page and basically catching people up who may have missed the first few questions. So I'm going to start my section of this webinar by asking the question, do you have a team at your facility that works on the Interact implementation? So that was the first ask of us. Our ask to you was that you set up an Interact team. So that survey should be going up shortly, the polling question. There it is. Now be mindful that this did not need to be a new team. It could be a team that's already working well for you and you just decided to add Interact implementation to that team. And do not forget to hit the submit button. Thank you. And it should be closing shortly, and we should have results for you.
I guess I could start singing if you'd like.
Oh, please, Mom. There you go. Okay, great. Wow, 62 of you. That's great. And for those of you who have not gotten a team together, I'm hoping that maybe you missed the first couple of sessions and did not know that you were supposed to get a team in place. And if you're struggling with that, please reach out to any of the contacts that you saw on the screen previously, and we can help you along with that. So great to see that. So my next polling question to you is the leadership at your facility committed to Interact? Yes or no? If you recall, early on we talked about the importance of having leadership engagement. In the study that was done by the Interact team before they, rolled this out, that was one of the biggest barriers in the successful implementation of Interact. If leadership did not have buy-in or did not get engaged, it just didn't work. As important as it is that you have a champion, someone who actually goes out there and preaches the word of Interact and gets people jazzed up about it, if everyone else is jazzed up but leadership is not, it really serves no purpose at all. Oh, awesome. Excellent. All right. I'm so happy to see that. Great. And for the 53 who did not answer, if you need any help at all in figuring out how to get your leadership engaged, please reach out to us. We are your resources and we're your support. Don't feel like you have to be out there struggling by yourself.
So the next polling question is, have you or a designated person at your facility actually downloaded and saved the 30-day hospitalization tracking tool from our last session? It should be coming up shortly. I think I'm too fast for the for the system here. There it is. The computer can't keep up with my fast talking. Don't forget to hit the submit button, please. All right, it's closed, and we should have some results shortly. Almost.
I'll wait here, okay.
All right, this is great. I am so impressed by you guys. Thank you so much. And for those of you who have not done it or did not answer, please reach out to me. It takes me 2 minutes to talk you through how to download and save that tool. If you are part of an ACO or preferred provider, you are going to need to have this tool to be able to communicate your 30-day readmissions to your providers. One last one. Is your facility currently entering data into that 30-day hospitalization tracking tool that you downloaded? All right, so the poll has ended, and we should be getting results in a few seconds. And as soon as we close out of the polling questions, okay, awesome. All right. About 50% of the people are entering data. Again, if you're struggling, if you don't understand how to do it, please reach out to us, especially me, because I'm working closely with everyone on the tool. So if you have any questions or concerns, this is what we're here for, and this is the reason we are doing these trainings. Do not suffer alone. All right, and I am going to now take you to the website to look at the quality improvement tool. So bear with me.
Sorry.
All right. Oh, there it is. I'm so fast. Okay. Technology, when it works great, it works great. So this is the quality improvement tool, and if you are unable to see this, I'm putting some screenshots onto the slide for you, the first two sections. So the quality improvement tool is a tool that reviews acute care transfers, and it was recently updated with conditions that CMS felt were potentially preventable conditions. The tool was updated after the Interact team reviewed more than 5,000 tools that other facilities have completed. And they wanted to include conditions that they saw reoccurring in these reviews. Because if you remember, Interact 3.0 occurred about 2-3 years ago. And this is why they named it 3.0, so that they can go in and update based on real data and what people are actually doing in the field. Now, this document has 5 different sections to it. And it's a huge document when you look at it, but most of it is check boxes because Interact wants to make your work as easy as possible. So the first section looks at the risk factors for hospitalization and readmission. So these are the conditions that are most common, and it's mostly, like I said, it's checking off boxes. There's not a lot of writing. So after you fill out the patient's, the resident's demographics, then you start to go into the tool itself to put in the conditions. And then section 2 actually will have you describe the acute change in condition or whatever led to the transfer. Now, this is where you need to actually put into words exactly what happened and when it started to happen. It has you looking at the vital signs at the time of the transfer. It also has you looking at conditions that were new or worsening. It has you looking at the lab results, any diagnostics that were performed. It's a very, very thorough form. Now, this form is not to be filled out by just the administrator and the director of nursing. Like Sheila said, it's important to bring everyone to the table who was involved in any transfer. So if a CNA was the one that observed a condition that was worsening, that person should be brought to the table along with your Interact team to discuss what happened and ask those 5 questions and perform your root cause analysis. So section 3 describes action that you took to evaluate and to manage the condition prior to having to transfer the person. So it talks about all the different tools that are involved in Interact. Some of them we have not talked about, like the Stop and Watch, the SBAR tool, the Care Path, and we will talk about all those tools in detail in other sessions. So as you can see, there's an area for, did you call the doctor, did you talk to the nurse practitioner, did they order any lab work, and did you have to do any interventions in your facility before you actually did the transfer? And this section actually also looks at advanced care planning and advanced directives. This section is another update that they put into it after reviewing the 5,000 tools. Section 4 will have you describe the actual transfer to the hospital, the date you did it, the time, and the day of the week. It has you looking at, did you talk to the physician to get permission to do the transfer? What was the outcome of the transfer? Just an ED visit? Were they admitted? Did the resident die en route to the hospital? And actually, believe it or not, there's been several questions that have come to me about this particular section when it comes to completing a 30-day tracking tool. So I guess it did make sense that they put it in here. And then it talks about factors that contributed to the transfer. So section 5 asks you to look at identifying opportunities for improvement. So looking back, what do you think your team could have done differently? And I always say to people, when you use this tool, it's not about finger pointing, it's not about blaming, it's looking at your system, your processes to make sure that everything that was supposed to be done was done. And you might use this tool and find out that we did everything we were supposed to do, and it ended up in a transfer. It was justifiable transfer. Don't forget that Interact is not saying that you should never transfer someone. It's saying that when you do transfer, that you do it as efficiently as possible. Some of the communities of care in our area in Connecticut have chosen to use this particular tool for their case reviews. So if you belong to one of our more mature communities, you will use this as a means of sharing information about your patients and your residents. You're allowed, Interact will allow you to make this form your own. So if there's some areas that you want to include or areas that you feel should be removed, you can do that. If you want to make it feel like your own, that's fine. But if you make any adjustments to this form, you will not be allowed to use the Interact logo, because at that point it's no longer an Interact form. And if you remember in the beginning, when you get into the website, you check that little green box that said, I agree. That's what it talks about, that they retain the right to keep their forms their own. All right. So I will move along, and I said that was going to be my last polling question. I think I told a fib. Here is my last polling question. After reading in this tool, will you commit to using this QI tool to perform a root cause analysis on your next hospital transfer? All right, it should be closing shortly, and I'll have results for you. I hope to see a lot of yeses. And I know I went through the form really, really quickly, so if anyone has any questions, please feel free. Oh, awesome, thank you. So the 53 that didn't really answer, I hope that you take the time to think about it and at least think about it. So, thank you very much. And now we will talk about the Medication Reconciliation Worksheet. This is another form that you can update in any way that you want to fit your needs. But if you do that, please, you cannot use the Interact logo on it. But I am asking to have everyone on the webinar today to at least try the form the way that it is. And then if you need to make adjustments to fit your needs, that's understandable. So this Medication Reconciliation Worksheet can be used on initial admission. It can be used with, and it should be used with every readmission back into your facility. This worksheet is intended to be a tool for your nursing staff. It's made to be used with your PAs, anyone that's associated with medication in your building. It's not intended to be part of the medical records. So your facility and administration will have to decide where you store this once you're done working with it. It is to be used to complete, this form should be completed before you call your provider. to verify orders. So in part one, you want to complete the column to the left by looking at all the meds that either someone brought in with them, and if you're having someone admitted to your facility, whenever possible, they should actually bring their bottles with them. That way you know exactly what they're taking versus a list that was made maybe 2 or 3 years ago that's incomplete. So you want to complete the left side with all the medications. We'll talk about a readmission. All the medications that were recommended by the hospital at discharge. And then you want to note in the middle section, do you need clarification for that? So you might need clarification if you have a med that you don't see an associated diagnosis with, or maybe a dose is written in one place and then in another area a different dose is written. So anything that you need clarification for, you complete that. Or sometimes, we get medication orders that don't have a root or an end date. So that's what that second section is about. And then you want to look at part 2, which looks at the medications that the person was on prior to the hospitalization that may need clarification. So let's say I was on Lasix 50 before I left, and then I come back and it's not addressed at all. They didn't say to DC it stopped taking it. It was not reordered. So this is the section where you put all those medications, and you want to write down clearly in the comment section why is that an issue for you, so that when you call the doctor or your provider, you have all the information in front of them and you can give a real quick, succinct report and your request. So in section 2 also you want to complete that and put the reasons for they had the medication before they went into the hospital, and the reason, if you know it, why the hospital stopped it, or the reason why you're asking the question. And there's a third section. I'm sorry, I thought I gave you a screenshot of it, but I did not. You want to complete the section that says resolution. Oh, it's right here. Resolution, like what was the resolution? Did the doctor give you an order to DC the med? Did the doctor give you an order to continue the med at a different dose? So you just want to make a complete picture so that everyone knows what the resolution was. And then you use this to now feed into their medication orders. Mm-hmm. So at this point, that is the end of my presentation, and we will open up the phone lines for anyone that has any questions broadly about the information that we've presented so far.
All right, so if you have a question, if you could press *6 on your phone to unmute your line, and go ahead and ask your question. Carol's actually going to start with a few questions that came up in the chat session.
Hi, everyone. This is Carol Dietz again. Florence and Sheila, thank you so much for those excellent presentations. The tools are outstanding, and the root cause analysis, you can't do your work without knowing why things happen. So thank you so much. It was really important information. Okay, so we have a question that has been typed into the chat about how can I obtain the 30-day hospitalization tracking tool? Well, again, you can go on Advancing Excellence and pull the tool off of that. It's called the Safe. Oh, don't tell me. Wait, I have it. Don't tell me. The Safe. Oh,
You want to go into the hospitalization field on the screen. It'll bring you to the tool.
Yes. But, however, the best thing for you to do is go on to our website. It is healthcarefornewengland.org. That is the New England QIN-QIO website. So I'm going to say it again, and Morgan is going to actually type it into the chat. It's called Healthcare for New England, all one word, .org. You're going to click on the event tab, which is right in the middle of the screen, and then you're going to scroll down to the bottom of it. It says Previous Events, and all our webinars, our past webinars on Interact are located right there. So my recommendation is to listen to the recording of our webinar from last month so you have a really good understanding about the tool and about the readmission tool and why it is so important. That's why we started our trainings with that tool, because in order to know where you need your quality improvement work, you need the data. So data leads the work, and I can't say that enough. So hopefully that will answer your question. You can also give a call to any one of us, and at our very last slide has our contact information for Florence, for Sheila, and myself, our email and our phone numbers. So you can always give us a call if you have further questions. So hopefully I addressed that. Any other questions concerning root cause analysis or the Med Reconciliation tool or the acute transfer on the QI tool for acute transfer?
If you need to ask a question, again, please press *6 on your line.
No questions.
Hi, Florence?
Yes.
Florence?
Yes. Yep, she's coming around the table. Yep.
Okay, this is Lori from Vernon Manor. So the 30-day hospitalization tracking tool, that's the one from Advancing Excellence?
Yes.
Okay, I just wanted to make sure.
All right. Thanks, Lori.
And the reason why we recommend using that tool is the exact same tool that's located on the Interact website. However, through the Advancing Excellence, if you give us permission, the New England QIN-QIO, to view your data, we can then get your data monthly instead of you having to send it to us if you're part of the communities of care work that's going on in Connecticut. So we're trying to take one step of work out for you by using this tool.
I just want to make sure there wasn't another one in Interact that we were supposed to be doing. So it all makes sense now.
Right. And the Advancing Excellence wants to connect you directly with the help desk, so it's a lot easier to work with.
All right, thank you.
Thanks, Lori. Great question. Thank you, Lori.
Any other questions out there?
Hi, this is Brenda Marinan from Chesterfield Health and Rehab. We are on Point Click Care, and they have the Interact tool associated with the hospital tracking tool associated with the admissions and discharges. How could I get you that information from there?
It's the exact same tool, and when you pull your report at the end of the month, there's about 5 or 6 numbers that you get. All you do is take those numbers and dump them into Advancing Excellence.
Okay. Thank you.
You're welcome. Thanks for the question.
And again, at the end of the month, if you just want to call Florence and she'll walk you through it, she would love to do that.
Hi, Florence. It's Lisa Clark.
Hi, Lisa Clark.
You know, I've been entering on the Advancing Excellence tool. It is a bit cumbersome. You can't easily tab between screens. You have to actually move your mouse and click. And you're actually having to do it all twice because you have to do it once for the post-acute and then once for long-term care. I don't know if you guys are going to look at a way to improve that efficiency of data entry at all. I'd be happy to work with you on it.
Actually, Advancing Excellence is working on that right now, so I may get you in touch with them to be on their team or, the piloting facility.
That would be fine. It is cumbersome if anyone else has entered. It's just time consuming when I think technology is advanced enough it doesn't need to be. Okay, thank you.
All right, thank you for that, Lisa. I will pass it on and tell them to hurry up the process.
That's okay. You know, I know you and I have talked, and some of the other facilities on the line may or may not have assisted living in their communities, but we would love to see assisted living as a drop-down choice as well, because we're tracking that for our assisted living, and that would be a great option to have.
Yes, and I have passed that on to Advance and Excellence as well as Interact, so I'm sure that the wheels are turning.
That's great. Thank you.
You're welcome.
All right, any other questions before we move on to our sharing session, state-specific sharing session? Those were some great questions. Thank you. Okay. Morgan has an announcement.
Yeah, just before you guys all jump off to hop on different calls to the state sharing part, I just wanted to give you a few last-minute announcements before some of you leave us. Within the next few business days, actually, tomorrow, we're going to be sending out an email that contains an evaluation for today's webinar. It will also include a link to where you can obtain the recording, presentations, and transcripts for today's webinar. They won't be available immediately, but they'll be there within the week. So make sure you guys are on the lookout for that, and please do fill out the evaluation, as it really helps make sure we're giving you meaningful programs. And we also want to remind you that the next Interact webinar is going to be on May 27th from 1 to 2 p.m. covering communication tools and quality improvement tools. So stay tuned for that. And I'm going to put one more thing in chat. Carol, go ahead. Oh, can I just say? Absolutely.
Since we will not be in touch with you, we will not meet again until after it occurs. Our team here in the New England QIO team would like to wish you all a happy nursing home week come May 10th.
Yay. Hope everyone's going to have a nice celebration, at least one celebration during that week. Thank you, Florence. Okay, so now the Connecticut nursing homes that are part of the Middletown, New Haven, and Hartford communities, please stay on the line. Everyone else from Connecticut can jump off. Also in New Hampshire, the New Hampshire homes, please jump off this call and redial to speak with Joyce Johnson. The number is 1-888-450-5996, and the passcode is 275687. We're going to be leaving this number up, this slide up for about 2 minutes. And all the other states, thank you so much for participating, and we'll see you next month. So Connecticut homes will be back with you in about 2 minutes. And the nursing homes from New Hampshire, Joyce will be waiting for you. So thank you so much, everyone, and we'll be talking with you next month. Connecticut homes, hang tight.